Hello, in this lecture we're going to talk about the trigeminal nerve, testing of it, the anatomy, MRI interpretation and diseases. For example, we have here a transverse image through a dog's head, and what we can see here, delineated by my arrow, is the normal temporalis muscle on one side, but a complete absence almost of temporalis muscle on the opposite side. Just a very thin streak coming down here. This is neurogenic atrophy secondary to a trigeminal nerve root tumour, which is here. This is the normal trigeminal nerve here. Now, the most important take-home message of this lecture, and really what inspires it, is that the trigeminal nerve is not the facial nerve. Now that may seem to be a very basic statement, but it's very common for the two to get muddled up. And I would have to say about 50% of the facial nerve paralysis cases that I get referred have been diagnosed, in inverted commas, with a trigeminal problem by their referring vets, suggesting that it is a common area of confusion. So let's compare the two. So, the trigeminal nerve has a motor and a sensory component, and the motor component is only in one of the three branches. The trigeminal refers to the three roots that the trigeminal nerves is composed of, and the mandibular branch provides motor or muscle supply to the muscles of mastication. So those are the big muscles of the head. If you think about yourself chewing something, then it's those muscles which are working. So the temporalis muscle, the masseter muscle, the pterygoids medially, the digastrus, and also some minor muscles which we're going to mention a couple of these later, such as the tensor veli palatine, the tensor tympani, and the mylohyoideus. By contrast, the facial nerve does the facial muscles in so-called muscles of facial expression in humans, because if you think about the muscles that you use to make a facial expression, such as a frown or a smile, these are the muscles which are involved. So there's the superficial muscles on the face, and these are also the muscles that move the ear and close the eye and move the lips and move food from the buccal part of the mouth into the central part of the mouth so that you can swallow. So the facial nerve does, most importantly, the facial muscles, and also does these other muscles here. The trigeminal nerve is the most important nerve for facial sensation, and so really covers the entire face, including the teeth, all the areas covered in pink. The outside of the ear and the sort of inner margin of the inner surface of the ear and the upper neck is the C2 nerve root, and the facial nerve really does very little for sensation. And I think this is the area which vets have confusion in, that they think the facial nerve does sensory to the face as well as motor to the facial muscles, but it's the trigeminal nerve which does sensation to the face, and the facial nerve just does the inner surface of the pinna, but not that outer edge. So when we're testing the trigeminal nerve, we have to bear in mind that there are three roots. So we have the mandibular root, which also contains the motor function, the maxillary roots, and the ophthalmic roots. The most important area to test, and the easiest way of testing facial sensation, because you've got a good comparison, is to tickle the inner surface of the nostril, and this is the ophthalmic branch. And we can also test the ophthalmic branch by getting a palpebral reflex by testing the medial canthus. So you touch the medial canthus and you should get a blink of the eye. Of course, as a reflex, the trigeminal is supplying the sensory arm of that reflex, and it's actually the facial nerve which is supplying the motor arm of that reflex, closing the eyelid. And so you do need to have intact facial nerve function. More on that later. By comparison, the maxillary branch, the autonomous zone for this is the upper lip, and I would normally test lateral to the upper canine, so a gentle tickling there, and the animal should be able to perceive this, and also you'll get a reflex movement of the facial muscles. Again, requires an intact facial nerve. And you can also test the lateral canthus of the eye and get a palpebral reflex. By contrast, the mandibular branch, the autonomous zone, is lateral to the lower canine tooth, so the lower lip. So how do we assess the trigeminal nerve function? So as I said before, we need to do a palpebral reflex, and bear in mind this is a reflex, so sensory through the trigeminal, motor through the facial. Now, they look different depending on which nerve is not working. And if the trigeminal is not working, then simply nothing will happen. The animal won't react to the eye being touched, or the palpebral area being touched, and there won't be a blink. However, if sensation is intact and there's a facial nerve paralysis, then the eyeball is retracted to protect it, and that is the retrobulbar muscle innervated by the abducens nerve, and the third eyelid will flick up to protect the eye. And the same will happen with the corneal reflex. So the corneal reflex is where you touch the globe, and again the eye should retract and the eyelid should close. And again, if that is if sensation is intact but there's a facial nerve paralysis, then you get that eyeball flicking back and the third eyelid coming up to protect the eye. Then we have sensation of the head, the ear, lip and nose, bear in mind that the inner surface of the ear is actually the facial nerve. So the most easy way to test this is by testing the comparison between the nostrils, where you should see a behavioral response, which means that the irritation is being perceived by the cortex, the prosencephalon, and then a reflex movement of those muscles, which of course is the facial nerve. So here we have an example of that. So this dog has a trigeminal nerve root tumour. This is involving the mandibular branch, and so we have this quite profound muscle atrophy on one side, as we can see here. But the dog doesn't have any sensory deficits, so we can see tickling the nostrils there, tickling the upper lip. See that reflex muscle movement, and there. Obviously, it's a very sensitive area, so you don't need to spend a lot of time poking around in there. And then we have the inner ear as well, which is the facial nerve. So we also need to look at muscle bulk. Now, this requires differentiating masticatory muscle disease. So this, for example, with this profound muscle atrophy, this is masticatory myositis, an autoimmune disease against the 2M muscle fiber, which obviously has a different embryological origin than the skeletal muscle elsewhere. And so it's possible to have an immune-mediated attack against that muscle and not the rest of the muscle. The differentiation, well, usually with primary muscle disease, despite this extensive involvement here, they can usually close their mouth, whereas in trigeminal disease, bilateral disease will result in a dropped jaw. Also, if there is unilateral loss, as we have in this dog here, then it is more likely to be the trigeminal nerve. We need to assess the jaw tone and the ability to close the mouth. So that's an example here. We can see in this cat, it's got normal jaw tone. It's difficult to open the mouth. Whereas in this little guy here, very much reduced jaw tone. With severe bilateral loss, the dog will have a dropped jaw. With unilateral loss, usually there's enough muscle power to keep the jaw closed, and it may be actually difficult to detect any weakness. So there's two examples here. This is a dog with bilateral lymphoma of the trigeminal nerve roots, and this dog looking very similar, but a much more benign disease, which is idiopathic trigeminal neuritis. Dogs with trigeminal problems will have dysphagia, making it difficult to pick up food, but they'll have normal tongue movement. So here's a little example. This dog is also compromised by the fact she has cerebellar involvement, so she has a bit of an intention tremor. Then you can see that she has difficulty taking the food out of my assistant's hand, and she has to use her tongue. And this really shows you how you have to support these dogs. If they're able to lick up the food, they can get it into their mouths, but they lack the ability to chew food and difficulty getting it in. Sometimes the jaw drop can be so severe that it is better to kind of tie the jaw up a little bit with a kind of tape muzzle, just to stop it completely hanging open completely. Now, it's not unusual to see some associated deficits with a trigeminal nerve problem, and the most common is a Horner syndrome. And this is because the sympathetic supply to the eye joins the ophthalmic division of the trigeminal nerve. And so as we see in this dog, now it has a sunken eye because of the loss of the pterygoids behind the eye, so that gives it a bit of a sunken eye. But this dog also has a Horner's syndrome. You can just see the third eyelid protrusion here. Her eye is so sunken that there is really no pupil that can be seen at that point. The other thing that can happen is that the parasympathetic fibers, the lacrimal gland, they come from the facial nerve, but many parasympathetic fibers actually hitchhike on the trigeminal supply. So that first of all, it hitchhikes on the maxillary nerve and then jumps to the ophthalmic nerve. And so animals with trigeminal nerve lesions may have a neurogenic conjunctivitis sicca, and you should, if you see a trigeminal problem, do a Schirmer tear test, because these animals do not feel sensation in those eyes, making them incredibly susceptible to severe corneal ulceration, because they have no pain response there if they've lost sensation. The eye is not protected because of the dryness, and also when you lose trigeminal supply to the cornea, then the cornea will lose its integrity. So a triple whammy, meaning these animals are incredibly susceptible to corneal ulceration. The other thing, which is less commonly observed, but you may see it, is a change in the saliva consistency. The most common change reported is a kind of thick, sticky or foamy saliva. And this is not because the trigeminal nerves supply the salivary glands, but again because it's a conduit for the distribution of postganglionic parasympathetic innervation to the head. So the innervation to the salivary glands is provided by the seventh nerve, facial nerve, and also the glossopharyngeal nerve, but they are traveling with the mandibular branch of the trigeminal nerve, and it is possible to see reduction in the size of the salivary glands on the affected side in some cases with trigeminal nerve disease. So I want to talk to you about the anatomy of the trigeminal nerve, and I'm going to use MRI for this because, well, maybe it's just me, but I find reading about the anatomy of the trigeminal nerve extremely difficult because the skull is such a 3D object and the nerves are such a 3D object. I find it very difficult just to show somebody that in diagrams or even by looking at images of the skull. So I want to share with you how I assess the trigeminal nerve on an MRI scan. First of all, I start with a mid-sagittal T2 weighted image, and I go parasaggically and find the nerve root as it exits at the cerebellopontine angle. Right there. That localizes me into the nerve, so then I get a transverse image and home in on that nerve root, and then simply follow it rostrally. We're following the maxillary branch here, and it's just coming up to the area of the round foramen, and it's going to be exiting there, and then we'll continue in the tissue as various branches when we're going to try and follow the zygomatic branch here, which is there in that region there, going forward in a kind of neurovascular bundle towards the general region of the lacrimal gland, etc. You can also look at T1 weighted with contrast. The normal nerve should not enhance with contrast, although you may see enhancement of the meninges around it. Remember, this is a very vascular area. That's the cavernous sinus, so you're seeing the blood vessels in that region with the nerves in there. And then again, we can see the neurovascular bundle leaving there and going again towards the orbital region. So that was the maxillary. Now we want the mandibular, a harder nerve to see. So first we have the maxillary ophthalmic going forward. The mandibular is curving ventrally, medial to the tympanic bulla, coming out of the oval foramen here. And actually generally don't see that nerve very well unless it's diseased. And here's an example of a diseased. So there we have the nerve root going rostrally and then coming down as the mandibular branch. And look how you can really see that nerve because it's so thickened in this particular case. So now we want to look at the ophthalmic branch, and I find it easier to start rostrally and work back for this branch. First of all, I find the bilateral orbital fissure, which to me looks like an alien or perhaps a frog, depending on the conformation of the animal. Then I can see that on the sagittal plane as well, and there is the nerve going up towards the eye. So having localized in on that, I simply follow it back caudally, as we can see here, till we get into the out of the orbital fissure and into the region of the cavernous sinus. We can see the maxillary branch leaving. Then we can see the mandibular branch leaving. Here is the diseased dog again. This time that bone does look a bit more like a frog. We can see the nerve much better because it's hyperintensed in this dog with disease. An inflammatory process. Again, we can follow it down back. We can see the mandibular branches leaving, which were very thickened in this dog. Back to where we started, to the cerebellopontine region. So since we've been talking about the anatomy of the trigeminal nerve using MRI, I'm going to continue discussing the MRI assessment of this nerve. So we often use contrast enhancement, and there's a few things to say about that. And it's that the nerve sheath and meninges will normally enhance with gadolinium. They don't have a blood-brain barrier, so it is completely usual for you to see the trigeminal nerve with contrast enhancement. And some actually say that the nerve itself will enhance, and certainly the ganglion appears to enhance because of an incomplete blood-brain barrier. Beyond the ganglion, the meningeal covering is lost, but this nerve sheath will still enhance. So this is an example of that. So you see the nerve sheath as these kind of tram lines, enhancing tram lines down the nerve. And this is not just true of the trigeminal nerve, this is true of the optic nerve and other nerves as well. And so inside the nerve, in my opinion, it doesn't normally enhance. You see it as a sort of same signal as the rest of the brain. Whereas the diseased nerve is often thickened, and you can see that it's enhanced and it no longer has the same sort of shade of grey as the rest of the brain. And I will use the parasagittal technique of looking at the nerve to compare those different sides. This is an example of the trigeminal ganglion. So it is just here, and actually easiest to see in the transverse images here on these T2 weighted images. This dog does have disease, and this is probably why we can see the ganglion much better, because we have a degree of meningeal enhancement which is more than normal, but we can just see the outline of the ganglion here like that, and here in this dorsal image, and these are both T1 weighted with gadolinium contrast. So the next thing to assess when we're assessing the trigeminal nerve is the masticatory muscle and other muscle bulk. And so here's another nerve root tumour. So we see the nerve root tumour here, and we can see the normal temporal muscle here compared to the atrophied muscle here, the pterygoids here compared to the atrophied muscle in this region here, the digastricus, which of course is the rostral digastricus, compared to the opposite side there, the masseter muscle compared to here, and the mylohyoideus is just here, but it's not something that we commonly assess. And likewise in this dorsal image here, we can see this very large temporal muscle, and complete absence down to just fibrotic neurogenic atrophy. So neurogenic atrophy often has that increased signal, as you can see here. And this is that trigeminal nerve root tumour. Typical appearance of a nerve root tumour, which is often described as an ice cream on a cone appearance. So you see the ice cream there, and then the cone coming down like that, and that's a sort of appearance that you will get with any nerve root tumour, like a nerve root tumour of the cranial nerve 8 as well. Here's another example of a trigeminal nerve root tumour, really just to show the anatomy as well. So you can see the nerve root coming forward and going towards the eye here, and here in the alar canal, and the large mass here, and here. And it's when this mass becomes a large size that the dog will start to have more obvious clinical signs. Often when it's just a nerve root tumour, you just see this asymmetrical muscle loss. When it gets to this large mass, then you can get other signs such as vestibular signs, facial nerve signs as well sometimes. So the next thing that we can see is a middle ear infusion, and this is because the trigeminal nerve supplies the tensor velo-palatine, palatini, which is the muscle of the soft palate. It's a very, very small muscle, and it tenses the small soft palate and helps to prevent food from entering the nasopharynx. But more importantly, from our perspective, it opens the eustachian or auditory tube, and that allows for pressure. So if you think about yourself up in an aeroplane and you've got increased pressure in your ears, you try to yawn, don't you? And that opens your eustachian tube. When you have a trigeminal nerve deficit, then this eustachian tube doesn't open properly and you get a middle ear infusion. Of course, this is often seen in dogs that are brachycephalic, like the Cavalier King Charles Spaniel and the French Bulldog, simply because they have a lot of obstruction of that eustachian tube anyway. Whereas this muscle, where it kind of goes between the bones, sort of medial to the tympanic bulla and attaches to the nasal pharynx, is very, very small. And this is that same dog that we saw the tympanic bulla effusion, and we can just see the normal side here, and this is the abnormal side, the normal side, abnormal side. So I want to talk a little bit about diseases of the trigeminal nerve, and there is actually not so many that we see, and you can really divide them into neoplasia and inflammatory. Of course, we also see pain syndromes, which I'm not delving into in this lecture. Most importantly, feline orofacial pain syndrome is thought to be mediated through the trigeminal nerve, and very, very rarely you can see infarction of the pontine nucleus of the trigeminal nerve, and it can be a reason for a peracute unilateral trigeminal problem. So neoplasia, lymphoma, often bilateral disease seen with lymphoma or with multiple cranial nerves involved. Nerve root tumours, or schwannomas, they're often called. Leptomeningeal carcinomatosis, that's when you have a carcinoma that's metastasized to the meningeal area and is sort of spreading along the nerve roots. Very rare, but I've seen a couple of cases in my career. Most common cause of acute onset trigeminal problems is idiopathic trigeminal neuritis. It's an acute dropped jaw. You can also see it as part of an acute idiopathic polyradicular neuritis, but this disease, so-called Guillain-Barré syndrome in humans, is typified by an ascending paralysis. It's actually very rare to be involving cranial nerves, but it will be seen occasionally. Disease described in textbooks like Hunter as polycranial neuritis, typically involving the facial nerve, trigeminal nerve and vestibular nerve. It's probably the same as bilateral cranial neuropathy associated meningoencephalomyelitis of unknown origin. So I would classify these as autoimmune diseases, which are, not these two. Then we have infectious causes, intracranial extension of otitis media interna. When I was looking and preparing for this YouTube video, looking through my cases of cats with trigeminal nerve problems, actually very few. And the cats were divided into this and lymphoma. So bear that in mind as a rarer cause. So a middle ear infection that's become an inner ear infection and extended into the brain. I've never seen this, but in endemic areas, Olszewski's disease or pseudorabies, which is a herpes virus infection, is an infection of pigs, but can affect other species, and infection is via the trigeminal nerve, and they can present with a facial pruritus because of that, and trismus, which is locked jaw. Lyme's disease, I've put question marks there. I have never seen that, but in endemic areas we'll often test for Lyme's disease as part of your kind of rule out with that. But I have to say I've not seen that actually confirmed as a cause of trigeminal disease in the literature. So this is clinical reasoning according to me, so it might be wrong, but this is how I think about trigeminal nerve disease when it's presented to me. If it is bilateral, acute onset and motor only, then it is much more likely to be idiopathic trigeminal neuritis. I think you can get sensory involvement with that disease, but it's much more uncommon, and typically it's just motor. And these are invariably, in my experience, golden retrievers. About when I look back at my caseload of this, I think about 50% of them were golden retrievers. If it's unilateral, then it's more likely neoplastic or inflammatory, and nerve root schwannomas. Nerve root tumours, again, in my experience, are more common in older male dogs, especially large breed Staffordshire Bull Terriers and West Highland White Terriers. Bilateral multiple cranial nerves, then inflammatory infectious or lymphoma, possibly leptomeningeal carcinomatosis, but that's extremely rare. Progressing over weeks or months, more likely to be neoplastic in my experience. And other neurological deficits localizing to the brainstem, again, more likely to be neoplastic, but could be inflammatory. So workup. Not every animal can have all of these expensive tests. So repeat neurological examination and monitoring. Certainly with idiopathic trigeminal neuritis, if the animal is acute onset, there is a spontaneous improvement with that disease, usually over a few weeks. Usually there will be some sort of improvement in 2 weeks. And I would just want to make sure that there wasn't any progression, because that disease progresses very quickly, say per acute, and then remains static. So I think it's certainly worthwhile in cases where there is a low budget, then to just do repeat neurological examination and monitoring. MRI, in cases of trigeminal neuritis, idiopathic neuritis, often the MRI in that is unremarkable. I have found that sometimes it's quite difficult to tell neoplasia from inflammatory disease. You can get pseudotumours of the trigeminal nerve, sort of ones where the nerve looks so thickened it could, or even lump-like, that it could be a tumour. Again, looking back through my cases, I was having to repeat MRI in quite a few animals to be sure that it wasn't a tumour. Again, your repeat neurological examination is going to tell you information about that if there is progressive changes. But some of these nerve root tumours are very slow growing, and so it's worth discussing with the caregiver that just because you're seeing a thickened nerve root doesn't mean that it's a tumour, and that it may have a very slow progression, and that it may be worth doing a repeat MRI. CSF analysis, I want to look at cell counts and protein to help differentiate inflammatory disease from tumours. I may want to do infectious disease testing. There was one case in the literature which suggested that you could get trigeminal nerve disease from Neospora. In my experience, that has not occurred. I mentioned Lyme's disease before, so I will, if I have the budget for it, test for those diseases. Lyme's disease only in endemic areas, really. A PCR for antigen receptor rearrangement test, the so-called PAR test, and this is a genetic test that helps distinguish between lymphoma and reactive processes. And I think that is very important if you have enough DNA to try to differentiate lymphoma from other inflammatory disease. And I put in brackets here an anti-2M antibody titer. I will occasionally do that, especially if I have very subtle disease, just masticatory muscle disease only, but I won't do it if I have sensory deficits. And finally, I just wanted to mention that the other function of the trigeminal nerve, which is often forgotten, is that it does proprioception in the head. And so muscle spindles provide feedback for coordinating jaw movements, and so again this is important for an animal that's eating and may contribute to their dysphagia. They help control eye movements by providing that proprioceptive input, and other proprioception of the mouth, especially the teeth. And the other just an anatomical quirk is that unlike other sensory neurons, the cell bodies of these proprioceptive neurons actually reside in the brainstem, in the mesencephalic nucleus of the trigeminal nerve. There isn't an outside ganglion for that proprioceptive information. So management of trigeminal disorders, very important if they have a drop jaw to give supportive care, assistance eating. You likely need to hand feed these dogs. You may need to experiment with different foods that they are able to get into their mouth. And it may not be what you think. Chicken, for example, is often what people go to with dogs with dysphagia. But chicken is actually quite slippery and difficult for dogs to negotiate in their mouth, especially when they have absence of proprioception and absence of jaw movement. And so sometimes balls of a soft, high energy food can be easier for them to pick up and throw to the back of the mouth using their tongue. You may need to, as I've said before, use a kind of tape muzzle to help partially close the jaw so it's not just hanging wide open to the world. There may be a medical management, so for immune-mediated disease, an appropriate immunosuppressive therapy. For lymphoma, appropriate chemotherapy. Sometimes you have to go in between the two if you can't tell the difference. So an MUO protocol will often include drugs that might be effective against lymphoma for example, cytosine arabnoside. Nerve sheath tumours, they are not chemosensitive, and I wouldn't recommend anything other than stereotactic radiotherapy for them. They're not particularly radiosensitive, again, in my experience, and I certainly wouldn't do a hyperfractionated radiotherapy for those. Those are the cases that I've seen the most side effects from radiotherapy. So it has to be very, very targeted, given by a LINAC or other kind of radiotherapy machine with a radio oncologist that really knows what they're doing. But these are very slow-growing tumours, and I certainly had one dog that survived 2 years with the tumour, so you don't need to refer for radiotherapy, especially if the budget isn't there. And in my experience, they cope well until the mass is large enough to compress the brainstem, and that will give you vestibular signs and other neurological signs that you would expect with compression of the brainstem. And at that stage, an anti-inflammatory dose of corticosteroids may help. So if you've been listening to this lecture and thinking, that's not what I expect, perhaps you were needing to have a lecture on the facial nerve, in which case I would recommend this is your next port of call. Thanks very much for listening, and goodbye.